All right, well, we're going to get going. Got some good cases to show you guys this morning. We also have, for the first time, the new dermatology residents that are in our program here, Lake Granbury. So they're going to join these conferences also. They might pitch in and describe a case or two if you guys want to let them. Of course, if you want to do it all yourself, that's okay too. But they're going to be on the calls too, so they'll get a chance to learn, see how you guys do this as well. So we got some 8 interesting cases. See how many we get through in the next hour or so. So who wants to give this one a go?
Okay, I can try. Hi, good morning. This is Bob, one of the new UT dermatology residents.
Great.
Okay, yeah, thank you. So this looks like a shave to me, like a shave biopsy of like a warty growth
Good.
to me.
So that's exactly right. It's a shave biopsy, and you can kind of predict what it would have looked like in the patient. Probably was kind of a pedunculated lesion, maybe kind of looked like a wart or a skin tag, you know, something like that. So that's great. Absolutely.
Okay. So I'm gonna walk my way from the top and go down. Starting from the upper layer of the epidermis, I'm seeing some thickening of the stratum corneal. So I see some parakeratosis and also some hyperkeratosis.
I think it's more likely to be an inflammatory process or a neoplastic process, just looking at this kind of a biopsy.
I think it looks more like a neoplastic process to me.
Good.
Yeah.
And would you say, based on the overall sort of architecture, would you favor this being more of a benign or a malignant lesion?
I would say more of something benign. I don't see a lot. I don't see like cytological atypia.
Well, if you see cytologic atypia at this power, you're probably like Superman, X-ray vision.
Yeah.
But there are other reasons, I think, that you know that it's likely to be benign. So at this power, we look at sort of the architectural features. So if we draw a line right down the middle, it's really quite
symmetrical. Yeah.
And it's well circumscribed, obviously. It looks like it's pedunculated papule. And it's not tiny, but it's not gargantuan. So it sort of has the 3 cardinal features of benignity at low power. It's relatively small, symmetrical, well circumscribed. And then, of course, we do want to look at the cellular characteristics when we go to higher magnification. So you notice that there was I don't have any problem with when you start analyzing, say you're going from the top down. I like to start even, you know, at a general power, just asking a couple of questions, whether it's inflammatory, neoplastic, is neoplastic, is it benign or malignant? And then we think whether it's epithelial or non-epithelial. So you were noticing the epidermis here. So do you think it's largely an epithelial process or non-epithelial process?
I think it's more of an epithelial process.
Yeah, it is. And you can tell the epidermis is really very acanthotic. It's got this really marked hyperplasia here. It's got these regular bulbous epidermal rhescia here that kind of vary in size and shape. So the epidermis is really a large part of this, which is one of the different epithelial differentiations in the skin. It can look like squamous epithelium, like follicular epithelium, sebaceous epithelium. So yeah, good. I think that's correct. And there's also parakeratosis. I think you're right. You notice at low power that there is something going on in the cornified layer. It's parakeratotic. And then you can see at this power, you've got some pallor of the epithelium here. This is an interesting finding we'll talk about in a minute. But okay, so we're looking at probably some type of benign neoplasm. It's certainly got a component of it that's epithelial. It's got a stromal component too, right?
Yeah.
It's got dilated blood vessels.
Yeah.
Okay. What else did you notice about this when you went to higher?
Yeah, there's something that also stuck out to me. There's a lot of elongation of the Regis.
Good. I agree with that. And is there
Okay.
anything else that you noticed when you, I presume you've already seen this, the slide, did you look in between these thick acanthotic areas of the epithelium here?
One thing that stood out to me is that when I went to the upper dermis, I see some cells that have like large pale cytoplasm that
Good,
looks
like
kind of
here, for example.
yes,
Good.
yeah.
Okay, so when you see pale cytoplasm like this, what does that make you think of? What's in the differential diagnosis of clear pale cytoplasm?
Something that comes to my mind is for how many histiocytes.
Good. And what can cause the foamy appearance of those histiocytes?
When it's like increased growth, um, that can contribute to it, like increased proliferation of cells.
Well, it's sort of, you have to, so when we think about differential diagnosis of things,
In terms of differential.
well, just so overall, this is just kind of a general sort
Mhm.
of lesson, if you will. So we think about differential diagnosis, we think about, the differential diagnosis of the actual diagnostic entity itself. So, is it a benign neoplasm, a malignant neoplasm? Is it squamous cell carcinoma? Is it something like maybe a verruca, something like that? And then you've got differential diagnosis of cells. So you see these cells here, and you have to say, well, what kind of things give you these cells with foamy cytoplasm? What's the differential diagnosis of foamy cytoplasm, of clear cytoplasm? So there's a differential diagnosis of the disease, and then there's a differential diagnosis of what's causing individual morphologic features of a cell, for example. So you
Yeah.
have to be able to look at this foamy cytoplasm and say, well, what are 5 or 6 things that can cause foamy appearing cytoplasm? So you ask yourself, why is it foamy? And
Okay.
so what's probably the most common thing that gives you foamy, clear staining cytoplasm?
For example, if you have accumulation of lipids or
Yes,
accumulation of
good.
glycogen.
Excellent. Lipid, that's probably the most common. And we also see you can get glycogen, like PAS positive glycogen within cells, like say, for example, the outer root sheath of the hair follicle, or the cytoplasm of some of the eccrine sweat cells that are clear staining cytoplasm. They have that they need to, they're absorbing electrolytes in the sweat, and so it's an active ATP dependent process. So they need glycogen to sort of burn and do that in a relatively, metabolically active way. You can get clear staining cytoplasm in certain neoplasms, like in, say, pagetoid malignant melanoma cells or balloon nevus cells, renal cell carcinoma. They can give you clear cells. A lot of those are related to lysosomes that can give you clear staining cytoplasm. So here, I think you're right. This is lipid. So we've got what looks like lipid-laden cells here, coupled with this marked verrucous epithelial hyperplasia, and all of this pink material here. This is due to maceration of the keratinocytes. These cells are macerated. Basically, it's due to trauma with heat. Some of the cells kind of get discohesive. There's some neutrophils in here. That's fairly common with this entity. So you may never have heard of this before if you're just starting out in your training, but do you have any idea what the diagnosis is here?
I was thinking it might be like it might be a Verruciform Xanthoma.
Yeah, good. That's exactly what it is. This is a Verruciform Xanthoma, and is called verruciform because it looks like a wart,
Yeah.
warty. It's not really like HPV induced. So if you go in and look for human papillomavirus here with PCR or something like that, you're not going to find it. It's not really and truly a wart. But basically what this is thought to be is some kind of a chronic reaction pattern to some sort of traumatic insult, and you get these secondary xanthoma-like cells that get deposited here. The epidermis gets hyperplastic. It's macerated. It's often seen in the genital area, and they look like kind of cauliflower-like warty lesions that are red and glistening. And when clinicians biopsy them, they often send them into us to rule out, something like a pyogenic granuloma, or they'll, they may think they're human papillomavirus induced because they look kind of warty, but they're not. So that's great. That's good that you were able to pick that up and make that diagnosis here. So this is Verruciform Xanthoma. A nice example of that. It's a good description. Anybody else have any questions or comments about it? Okay, great. Good job.
Thank you.
Okay, let's move on to the next case. See if anybody wants to give this one a go here.
I can give this one a go. Can you hear me?
Yeah.
My name's Wiley. I'm one of the new UT residents.
Okay.
So I see a shave biopsy, probably from trunk or extremities, because I don't see a lot of hair follicles. On high power, I don't see a whole lot in the epidermis except maybe some acanthosis in the middle. And then I see some cells in the dermis. On this high of power, I wouldn't be totally sure if it was inflammatory or neoplastic, but if I zoom in a little bit,
That's good.
I think
Okay,
this.
that's great. That's very good, by the way. So at low power, sometimes you can't tell. You say, well, at low power, there's definitely some cells in here. They're kind of pale, and there's some others that there may be some color of some sort up here. We're not sure. Could it be an infiltrative histiocytes? Could it be some kind of a pale neoplastic cell? We're not sure at this power, so we're not 100% certain. But we don't see any classic inflammatory pattern like a lymphocytic infiltrate, for example. We don't see any blistering. So we don't see anything that looks like a classic inflammatory condition, unless maybe it's granulomatous or something like that. So that's good. If it's a neoplasm, would you think it would be more likely to be benign or malignant based on what we're looking at here? It's based on that same kind of architectural criteria we just went through in the last case.
I would probably say that it was benign.
Yeah. If it's a neoplasm, we're not sure 100% yet, but if it is, again, you can draw a line right down the middle. It looks, this side looks much like the last side. The whole thing looks fairly small. So again, at low power, we're going to favor this being benign if it is a neoplasm. So we will go to higher magnification. You said this is high magnification. What is this? Electron microscopy or something? Actually, we talked about scanning magnification or low magnification, then we moved to higher magnification. So we're now at a little higher magnification, probably about maybe 10x on the microscope. And now what do you see?
Now I see a bunch of non-inflammatory cells. They're lighter in color, maybe a little bit epithelioid in shape. Originally, when I looked at this slide, I actually thought they were maybe melanocytes, but on closer inspection, I think maybe more in the histiocyte range, just because they're a little bit more pale.
Okay, that's a possibility. There's a couple. What about this here? I'm pointing to right there, that sort of dark material.
Yeah, that might be melanocyte dropping from the epidermis. I mean, I meant melanin, not melanocyte. I meant melanin.
Well, it is melanin, and I think some of it actually may be in the cytoplasm of some of these cells here. So it actually, when you see melanin in these cells, and they're also noticed that some of them are beginning to kind of form these little nests right here. So I think your first impression was probably correct, but it's possible, if you're not sure that you think they might be histiocytes, you can always do an immunoperoxidase stain, and you could prove that they're like S100 protein positive, maybe SOX10 positive, something like that. So if you're not sure, that's certainly, you can always do that, but let's say they are melanocytes.
Okay, yes. So if they're melanocytes, I think I could prove that, because you can actually see little pseudonuclear inclusions on some of them. But they're not super well defined, and there is some melanin. So I think my top differential would probably be a blue nevus. just because of the architecture and the melanin plus the melanocytes.
Now, usually in most blue nevi, you get more melanin in this, that not always. There's a type of hypopigmented blue nevus that just has a lot of thick sclerotic collagen with relatively minimal amount of melanin. And the cells usually, there's two types, there's several types of blue nevi, but the two most common type are the dendritic type that have sort of dendritic thin melanocytes, and there's a cellular blue nevus. Usually those are much larger, deeper, have a more thickened sclerotic collagen. But this does have an interesting morphology that is in common with the blue nevus. This kind of stroma here, which is somewhat thickened and looks almost like the collagen of the tendon. I don't know if that rings any bells for you at all. This is more for an upper level resident, but
one thought I maybe had, this could be wrong, is because it kind of goes deeper, you could think more congenital nevus. But I think you're looking for something else.
yeah, it's for the old guess what I'm thinking kind of thing. But yeah, and it might actually be a congenital nevus in some ways. It's usually congenital nevi. We will see splaying of the melanocytes around pre-existing hair follicles. There's maybe a little bit of that here. When you get this sort of thickened sclerotic collagen in association with the nevus, there's a term called desmoplasia, and desmos is the Greek word for tendon. And so it means that the stroma of the lesion is developing this kind of histology that looks like that of a tendon if you biopsy it and looked at it. It's mostly just a lot of thickened collagen there. So you can see these collagen bundles are really thickened and a little bit sclerotic here associated with these nevus cells. So this is a variant of a nevus, and there are a lot of different types of melanocytic nevi. You mentioned blue nevus certainly is one. You can get Spitz's nevi, so-called dysplastic nevi, congenital nevi. There's about 50 of them. And this is what's known as a desmoplastic nevus. It's a variant of a nevus in which there's this thickened tendon-like collagen associated with nevus cells in the background. And so these are, again, I don't like to get into the type A and type B nevus cells, but these would be the so-called type A, small, round, almost cuboidal types of nevus cells. They're relatively homogeneous. There's no mitotic figures, no atypicality. There's no multinucleation, anything like that. It's just a variant of a melanocytic nevus. And it probably at low power, I agree, you can't really tell for sure it's melanocytic. I mean, it could even be histiocytic. So that's certainly not unreasonable. And when you see histiocytes plus sclerotic collagen or altered collagen, you think of some of the palisated granulomatous dermatidities like GA or necrosis lipoidica, those kind of things. So that's reasonable to think of at low magnification. Your higher magnification, you start seeing the melanin and the nesting, you think more of a nevus. I'm not sure this is a type of lesion that they would show you on a board examination. It's a little bit too unusual, but it's just mainly we wanted to put in here just kind of show you an unusual variant of a nevus. Notice there's limited involvement of the epidermis, so it's mostly a dermal nevus with this just interesting stromal pattern. And it might be congenital. These funny lesions like this sometimes are congenital in nature. So that's very good.
Okay, thank you.
You're welcome. Good job. Go to the next case, and it's kind of an interesting one here. This is a very important one because this is the kind of thing that you most definitely will see once again on the board examination in one way or another.
I can do this one. My name is Adrian. I'm also one of the new UT residents.
Okay.
So it looks like we have a punch here, possibly from like a trunk or an extremity. On low power here, I think the most obvious thing we can see is this kind of like intraepidermal split. Looks like there's also some significant acantholysis in the epidermis. Also some like perivascular infiltrate as well. Moving closer, it looks like the basal layer is still attached to the dermal papilla. I think in some areas it kind of looks like that tombstoning appearance as
Okay.
well. So I think I was thinking that this was most consistent with like pemphigus vulgaris. I also thought about Haley as well. possibly even
Okay,
like.
so what's the, you're in the right, you're kind of moving in the right direction, but what's going on up here? These cells. So you got this part right. But
Yeah,
look closely at these cells up here. What color are these cells?
they're very pink. They look like they're like dyskeratotic keratinocytes.
Good, good. So you talked about acantholysis, and I also notice, is this diffuse over the entire process, with entire biopsy?
No, it looks like it's just kind of focal.
Focal, good.
Mhm.
Focal, acantholytic, plus these, which you just said, dyskeratosis. So this is a reaction pattern in the epidermis, and it's known as focal acantholytic dyskeratosis. So this is one thing that you definitely need to recognize. And these are what in the textbook you'll read about the corons and grains, the French word for round bodies and grains, basically just acantholytic dyskeratotic parakeratotic cells. Corons are just acantholytic dyskeratotic granular and spinous cells. It's nothing special. It's just back in the old days before they knew what this was, they just described it in French. And so it doesn't mean anything, except when you see this plus this, that's the reaction pattern. And it's just like spongiosis, for example, or like ballooning degeneration. It's one of the most important epidermal reaction patterns in dermatopathology. So you need to know this pattern and be able to recognize it. And it's not usually seen with the pemphigus group of diseases, for example.
Right.
You don't usually see this in pemphigus. If you see pemphigus vulgaris, for example, you'll see these kind of acantholytic cells here at the roof of the blister also, or you'll see this kind of a sloughing, and then you'll see just a few of those acantholytic cells at the bottom of that blister. If it's Haley-Haley disease, you'll see these acantholytic cells diffusely throughout the epidermis, but you don't see the dyskeratosis. So that's what distinguishes this reaction pattern just from acantholysis, whether it's full thickness, whether it's suprabasilar, whether it's just subcorneal in the various forms of pemphigus. So there's a different group of diseases that give you this pattern. It's a different mutation. Yeah, those are often immunobullous. This is more of a mutation of a keratin.
I also had like Dariers and Grovers on the differential because I did see that there was a lot of the dyskeratotic keratinocytes as well. So
Good. Yeah, see, that's the differential you want to go down into. So once you recognize this, you throw out the pemphigus group of diseases and you go down the pathway of the diseases that give you focal acantholytic dyskeratosis, which is Dariers, Grovers. There's a few other diseases in there. Do you know a couple of other things that can give you this pattern?
I think warty dyskeratoma can also give you that as well.
And now that wouldn't really be good for this specific
Right.
biopsy. This will give you like a cyst, like an inverted lesion. There's a couple of others though that can give you this pattern. The good news is there's not 20 of them. There's really only about 5 or 6 diseases that you need to know, but you do need to know the pattern.
Yeah. I'm not sure.
Sometimes the patients will come in with just one lesion, and it shows this phenomenon, a solitary acantholytic keratosis. So it can look clinically like a basal cell shade biopsy, and it gives you this pattern. It's just coincidental, doesn't mean anything. There's a thing called familial dyskeratotic comedones that when you biopsy it, it looks like this pattern as well, only it's kind of in little sort of small, it's not like a warty dyskeratoma, it's like little small comedonal like lesions. And then there's a so-called linear Darier's disease. It's not really linear Darier's disease, but it's a epidermal nevus. It's a nevoid mutation in the skin where they get a linear areas of focal acantholytic dyskeratosis. And that's about it. So the good news is there's really not a lot of diseases that can cause that, but the most important thing is to recognize the pattern, and then, because you'll see this on the board examination. It will definitely be on there. I think they know the gene mutation now that's associated with this. I'm not a molecular, pathologist, but I would recommend knowing anytime there's a gene that's been discovered that causes these, like the Nemo mutation in Cutaneous pigmenti and tuberous sclerosis, know those. I'm pretty sure this is a keratin gene mutation that's associated with this. Okay, that's good. So this is focal acantholytic dyskeratosis. It's a good thing to kind of learn about early on in your training. So good job. Okay, anybody want to do this one?
I can do this one. This is Kavina. I'm also one of the first years at UT Houston. So starting off, this looks like a shave biopsy to me.
Good.
And it looks like it might be on the hair bearing area because I see some hair follicles.
Yep, I agree with
On low power, I see these groups of what look like basaloid cells. And then there is also some like pink fibrotic stroma surrounding them.
Yeah, good, excellent. So do you think this is a neoplasm?
Yes, I do.
Yeah, yes, neoplastic. So would you favor benign or malignant here, based on our sort of features we've already kind of talked about this morning?
More likely benign.
Yeah, most likely benign. If it's malignant, it's going to be a very low grade kind of thing, but it looks, once again, very symmetrical. We can draw a line right around it. It looks very well circumscribed. It's obviously very small, so this is kind of low power. You see this little tiny papule, and it's, this might be on the nose or somewhere like that. So it's a small lesion. So obviously we're going to favor benign here. So do you think it's epithelial or non-epithelial?
I do think it's epithelial.
Yeah. And so what type of epithelium?
Follicular, because of the hair follicle.
Yes. Good, good. Now there's 3 parts of the hair follicle, right? You remember what those are?
The infundibula.
Good, like right here. So this is the infundibulum of a hair follicle. Then what's the other 2 parts?
What ostia?
Well, there's the isthmus, which kind of occurs between the infundibulum, and then there's the inferior portion, the lower portion. So it's not rocket science. It's just basically infundibulum, the isthmus, where the mantle zone of the follicle lives, and then the inferior portion where the hair bulb lives. And that's where you get the part that cycles when you have your hair goes through anagen, catagen, and telogen cycling. So basically, you're looking at those 3 parts of the follicle. If it's a neoplasm of follicular differentiation they look kind of like little cysts like this, it'd be more like infundibular differentiation. If it looks more kind of like primitive stem cells and whatnot, it'd be more the inferior portion, like near the hair bulb. So you're right, this is follicular, and you can tell that it's kind of differentiating more towards the inferior portion of the follicle. So do you have any idea what the diagnosis might be?
Yeah, so I was thinking that this could be trichoblastoma or trichoepithelioma.
Yeah, I agree. I think it's in that category. This is a little papillary mesenchymal body. So you can see there's like it's trying to recapitulate the little dilated blood vessels at the bottom of a hair papilla. And so it's kind of forming that little structure right here. Here's another one over here. So it's really recapitulating the inferior portion of the follicle. This one's maybe this is probably really from the mantle zone, those stem cells that are kind of in that area. They can also form these little stem cells that can kind of look like the inferior portions of a follicle. It's not a classic trichoepithelioma. Those usually have cysts and whatnot. So we call this just a benign follicular hamartoma, but I think if you wanted to call it like a variant of a small trichoblastoma or something like that, that's perfectly fine. So the main teaching points on this is understanding that it's benign, it's epithelial, it's differentiating towards the inferior portion of the follicle. And there's one other thing that you said a second ago that's absolutely correct. You talked about the stroma. So what is characteristic of this stroma that favors this, say, versus a basal cell carcinoma, which is obviously the #1 item in the differential diagnosis here?
So this one looks a lot more cellular.
Good. It's got fibrosis, with this collagen here, and it's got an increase in the number of the fibroblasts, and it does not have much mucin. So if you see the stroma surrounding a basal cell carcinoma, it's really more fibromucinous. This is more fibrotic, like you said. And notice that there's no cleft between the actual neoplastic cells and the surrounding stroma. That's very characteristic of these benign follicular hamartomas. They don't really have clefts surrounding them. And if you look at the inferior portion of a normal hair follicle, there's no cleft between that hair papilla and the hair bulb down there. So a basal cell carcinoma is a different kind of stroma, and it doesn't stick together with that stroma. And so if there is clefting, it's between individual collagen bundles and fibroblasts like here, as opposed to between the neoplasm and the stroma. So that's another helpful clue to the diagnosis. This is really probably a real cleft here, but that may be kind of a histologic artifact. But still, this is not a basal cell; it's a benign hamartoma with follicular differentiation. Okay, good. All right, we've got another one here.
I'll do this one.
Okay.
So here we have another shade biopsy from low power. It looks neoplastic. It's pretty small and well circumscribed, a little bit less symmetrical than the previous ones, but I think I would still err on benign.
Okay, I agree with you. It's very well circumscribed, and sometimes when it's got multiple small aggregations, you sort of look at the individual aggregations themselves and see what they look like if the individual aggregations are kind of small and symmetrical, and so they are. But yeah, I agree with you. I think I would strongly favor benign here.
Okay. So kind of similar to the last one, it seems like there are some basaloid lobules within the dermis, which makes you think of kind of the like basal cell mimickers. And then so there's a lot of looks like lymphocytes throughout the dermis.
Yes, there are. I agree with you. What about these cells here?
That looks like kind of like what we were talking about earlier, like glycogen.
Good. Yeah, these are clear cells also, like we had the clear foam cells. Here we've got clear cells, and they look a little different. There's not really there's maybe some little tiny sort of vacuole-like structures here, but I don't really see that sort of fine little droplet-like morphology that really looks more like lipid in the cytoplasm. So I agree. I think that this is more likely glycogen that's causing the clear color of these cells.
So for this one, since it has like the basaloid features with the lymphocytes in it, in the glycogen within the lobules of the basaloid lobules, I was thinking lymphadenoma.
Okay, good. So tell us about lymphadenoma.
So it's like a benign epithelioid tumor, usually just firm, like demarcated kind of skin or pink colored nodule, usually on the face or head.
Yeah, I mean, it's a pretty rare tumor. We really don't see very many of these. I think that's why we wanted to put this in, just so you'd be exposed to it. I doubt you're going to see this on the board examination. It's really sort of controversial as to exactly what the differentiation of these individual basaloid aggregates is. Some people think they might be sebaceous. Other people think they might be adnexal. I think when you look at something like this, to me, that kind of favors that there may be more likely something like a sweat origin, eccrine or apocrine. You've got all these little clear cells. So I kind of think of these as being sort of analogous to probably an eccrine lesion, especially when you get this many clear staining cells in it like this. And other people think they may be follicular. So I'm not really sure where the current thinking is on the actual differentiation. of this is. But no, that's good. This is an example of a lymphadenoma. It's a pretty rare tumor, and we just don't see it too terribly frequently. Now, what's in the differential diagnosis of this? And it gets a little more sophisticated here when you see lymphocytes within an epithelial neoplasm, a basaloid epithelial neoplasm, that the cells, the lymphocytes are actually in the
Right.
epithelial aggregations.
Mhm. I think on the differential, similar to the last one, is like trichoblastoma or trichoepithelioma. If you didn't really zoom in, you might just think basal cell too.
Those usually have lymphocytes, though, within the actual neoplastic aggregations.
No, those don't.
They don't. That's right. So if you wanted to like hone down on a potential differential diagnosis that actually gives you lymphocytes within the epithelial aggregations, what would you think about?
Um,
Pretty rare. It's not something that, if you get it, it's surprising.
sure.
Yeah, actually, a dermal thymus is another condition where you can sometimes see it's where it's like a brachial cleft remnant. It's on the head and neck area. Biopsy it, and it's little rests of thymus tissue that's there. You get epithelium and sometimes squamous epithelium with Hassel corpuscles, and then all the lymphocytes are actually present within the basaloid aggregates that are there, as well as some of these squamoid elements that you see. But that's super uncommon. I don't think you really need to know that. It's just more of something that you would think about in the differential diagnosis. And one other thing, if you were to see if these were hair follicles and you get lymphoid aggregates within the hair follicles themselves, and there's some clear staining material in there, you kind of want to think about follicular mucinosis, which you can see with mycosis fungoides. But that wouldn't really be a neoplasm like this. So this is a dermal example of lymphadenoma. So that's good that you were able to diagnose that. Yeah, any questions about that? So we got a lot of neoplasms this morning. Usually I like to have kind of a mixture of more inflammatory things, but we'll get a good dose of epithelial neoplasms today. Anybody want to try this one?
Yeah, I can do this one. Good morning, this is Kevin. What stands out to me is this, I guess, big kind of purple to blue cells that are infiltrating in the dermis. I think this is also neoplastic as well. It looks well circumscribed, so likely benign from this low power here.
And notice that it's just like the last one, we had like multiple little small basaloid aggregates, and in the previous one before that, we had little small basaloid aggregates. Here we've got like one here, another one here, another one here, another one here. So we've got like multiple of these little purplish aggregations in the dermis.
Yes, and they look pretty large, and it also looks like there's some pinkish material inside the islands of the purplish islands. It looks at higher power, looks more like hyaline material inside.
Okay, so you think this is a benign or malignant neoplasm?
Benign.
Okay.
Yeah.
And then we'll go to higher magnification. And what kind of differentiation did you think that this was exhibiting?
So I saw some lymphocytes in the cells. I thought this was more of eccrine or sweat gland.
Why did you think that? Just out of curiosity.
So it looked like there was some. So it looks like there was a lot of black lymphocytes peppered. I think there looked like there were maybe sweat gland ducts in the other parts of
ductal differentiation, that can help. If you look at a normal sweat gland, what cells are present let's say in the cells of an eccrine sweat gland down near the bottom of it, where you have the coil of the eccrine. What kind of cells? What do those cells look like?
Are they usually cuboidal, or I don't
They
know?
are good. They are. They're small. They're basophilic and they're cuboidal, and they're admixed with other cells that have more of a clear staining cytoplasm, like that last case we saw the clear staining cytoplasm there that was more prominent than here. So that's what's kind of normally present at the base of an eccrine sweat gland. So if you get a neoplasm that differentiates toward that, it's going to recapitulate those same kind of cells. So if you see a neoplasm that's got these small cuboidal cells, and maybe there is evidence of ductal differentiation in here like this, you'd say, well, this favors that this is potentially an eccrine neoplasm. So that's what you look for there. And what about an apocrine sweat gland? What do you see there?
I'm not sure. Would it be more columnar, or I'm not sure what.
Well, you see the apocrine or decapitation secretion.
Okay.
Those cells are a little bit more elongated. They're a little larger than the small, round cuboidal cells of an eccrine sweat gland, but they have the classic decapitation secretion. So we don't really see that here at all, do we? We just see these small, round cells. We do see some areas that are suggestive of ductal differentiation, some foci. And then you mentioned that there's some pinkish material, some hyaline material kind of between the individual cells. That's also characteristic. And then obviously some vascularity here. So what's the diagnosis here?
So the top of my diagnosis would be a spiradenoma.
Yeah, that's correct. That's the right answer, by the way. But let's say you're looking at an exam and you've decided that that's going to be your diagnosis of choice, and then you look down, maybe it's a list of 4 other items, and they've got some other things in there. They might have something like Merkel cell carcinoma. They might have metastatic malignant melanoma. They might have a follicle center cell lymphoma, something like that. So other cells that have basaloid morphology is what you're going to need to make sure that you can distinguish between this lesion and those other lesions, or among those lesions. So you'd feel pretty comfortable that you wouldn't confuse this with any of those, correct?
Yes. Yeah, now that you've explained it, yes.
Good. Well, some of the things you want to look for are, if you look for ductal differentiation, these cells are small, they're homogeneous, there's really no large atypical cells, there's no mitotic figures, there's nothing like that, there's no melanin. It is the old adage is multiple blue balls in the dermis is what they talk about here. And a low magnification, you do see this. Now, what's the clinical presentation of this lesion?
Usually they're like blue or gray, like subcutaneous nodules that are usually pretty like tender or painful. Yeah,
this is one of the painful tumors. Yeah, they talk about them being, quote, subcutaneous, but as you can see, it's not subcutaneous at all. It's sitting right here in the mid-reticular dermis. So they feel like a dermal nodule. And yes, this is one of the painful tumors. I'm sure you probably have your mnemonic device of choice as to what you use to remember those 5 or 6, 7 entities. But this is one of those. So Eccrine Spiradenoma is classic. These are not usually diagnosed by clinicians. I'd say the vast majority of these that we get submitted to us come in as just cyst. So they don't really think of them as being neoplasms. Now, is there any syndrome that's associated with this entity?
Yes, the Bruch-Spiegler syndrome.
Yeah, and there it's when you get kind of lesions that look like a cylindroma and a spiradenoma kind of together. Those are both kind of related lesions. If you see one that's kind of got features of both, it should trigger in your mind the possibility of the Bruch-Spiegler syndrome. We won't necessarily go into all the clinical details of that, but I would recommend that you know that entity and know the various tumors associated with it and the internal neoplasms that can be associated with it. They might ask you to diagnose this and say what syndrome is associated with this entity. And then you'd have to know Brooks-Spiegler, and they might say a syndrome is associated with an entity that's associated with which of the following underlying neoplasms. And then they might expect you to know, say, GI or breast or thyroid, whatever the other entities are associated with that. Okay, now we do have an inflammatory process.
Hi there, this is Anna. I'm one of the first years at Baylor. I can take this one.
Okay.
So looks like a punch biopsy, perhaps on the trunk or extremity. And like you said, this is an inflammatory process. Immediately I kind of see some epidermal change or disruption, and then you can also see some dermal processes going on, some cells there as well at this lower power.
So what pattern would you put this into?
I would say this would be either like well, after looking at it, I would say one of the subcorneal pustular differentials. And then
superficial perivascular dermatitis here with a blister, and it's a subcorneal vesicle. Good, I agree with you. Intraepidermal vesicular dermatitis with the blister situated beneath the stratum corneum primarily. What about the epidermis? Does that look normal to you?
No, I think it's a bit acanthotic at this power.
Yes, it is. It's acanthotic. This is probably closer to normal over here. So yeah, it's thickened. It's got some irregular psoriasiform hyperplasia. So yeah, I agree with you. What kind of cells do you think we're looking at here at this power?
They look like lymphocytes from here.
That's a good picture too. I mean, when you look at low power, they kind of look like dark black dots. They're almost always going to be lymphocytes. So you're exactly right. These are lymphocytes. And then we'll look at the epidermis and see what we see here. What kind of cells have we got up in this area?
Up here, we see neutrophils in
Yes.
this.
Yeah, we've got neutrophils within the space between the cornified layer and the underlying granular cell layer here. And then what have we got going on in this area?
I would also say those look like neutrophils.
Yeah, there's neutrophils in the epidermis. It's actually forming a little spongiform pustule. And so there's a number of kind of historical names that are given to these kind of changes.
Yes, you can call them, I'm not sure if I'm pronouncing this right, but the Kojo.
Actually, that J is pronounced like an I, so it's Kagoi, believe it or not. So
Okay.
pretend like I think the guy was maybe from somewhere in the Eastern Europe, and the J there that at the end is pronounced like an I, so it's Kagoi.
Got it. Thank you for clarifying that.
Everybody mispronounces that, but let's just look at it, just pretend like it's an I, just like the J in jalapeno pronounced like some kind of idea. And then, but you have the subcorneal pustule. So what's the differential diagnosis when you see subcorneal pustular inflammation with neutrophils here?
Yes, there's quite a broad one. Some things on my differential. So AGEP, the acute generalized exanthematous pustulosis is one of them. In that differential, you tend to see some eosinophils, which I think I was able to pick out while looking. And clinical history obviously will help support. And then yes.
There are some in there. You're exactly correct.
Yes, some little ones. And then other things on the differential. So you can think of apustular psoriasis, in which you might see a few EOs, but definitely less. And then you can sometimes pick out the hypogranulosis, the superpapillary thinning. You might see it on an acral site, which might clue you into that. Other things on my differential for this would be like a bullous impetigo. Obviously a gram stain would help with that, but then I think sometimes if they're not washed out, you can actually see the bacteria even without just on H&E. And then you can have tinea or Candida as well. So a tinea, a GMS or PAS stain could have. And then with Candida, sometimes you can actually see the yeast and pseudohyphae in that kind of north to south diving pattern. And then going down, we have Sneddon Wilkinson, This is something that, again, I think you can or cannot have eosinophils, but typically my understanding is it won't disrupt the epidermis as much. And you can also have like an IgA pemphigus, in which a DIF would be really helpful to clue you into that. And lastly, I'll say a staph scalded skin syndrome, in which you can have like the same acantholysis, subcorneal split, but typically you won't see bacterial inflammation in that one because it's the toxin going through the blood disrupting a distal site from where the bacteria usually is.
Yeah, that's perfect. That's exactly what you should think about. All those are the things that are in the differential diagnosis. So, and that's it. So your description and whatnot was just absolutely spot on. So that's exactly what you would want to think about here. IgA pemphigus, some things that get into the literature and get into derm textbooks and teaching conferences and things like that. Is extremely, extremely rare. I've been looking for that here with immunofluorescence for about 25 years. I've never seen a case. So it's really, it's out there, but it's extremely uncommon. It's just like urticarial vasculitis. For every real urticarial vasculitis we see hundreds of thousands of benign urticarias. So you should think about it, but it's super rare. Snedden-Wilkinson, pustular psoriasis, AGEP, in my view, and geographic tongue, basically same sort of thing. They're all variants of pustular psoriasis. So if you think about AGEP, it's probably somebody that's got the tendency to have psoriasis. They get a drug eruption and boom, they get, basically widespread pustular psoriasis, almost kind of like guttate psoriasis after a strep infection. Basically, it's kind of the same concept, if you will. I'm not sure it's a disease itself, but this is AGEP here. And I think if you do see a fair number of EOs, it kind of favors it. But I've seen lots of psoriasis cases with EOs. You get EOs in tinea, in bull's impetigo, in Canada, you get EOs, and anytime you get any kind of an infectious process, you get eosinophils. So you'll see EOs in those conditions as well. So at the end of the day, you may have to just correlate it with clinical, with cultures, with stains, like you said. So they can look a lot alike. But this is an example of AGEP in this case. So you can see how much it looks like pustular psoriasis. To me, when something looks the same under the microscope, I tend to think it probably is the same, probably the same basic disease, or it's very clear, some kind of histologic identical twin like bullous pemphigoid and pemphigoid gestationis. It's the same general concept. So to me, if it looks like pustular psoriasis, but it's AGEP, it's probably the person's got a psoriatic genetic tendency, and then a drug caused them to get psoriasis or pustular psoriasis. So that's just kind of the way I think about it. So that's very good. So very good differential diagnosis, exactly the way you want to do that.
Thank you.
I got one last one here, kind of another esoteric sort of thing.
Hi, I can do this one. So this looks like a punch biopsy, probably from trunk or extremities. It's the dermis looks pretty deep. From higher power, I see like these duct-like or maybe even cyst-like structures. With the cyst.
Cyst or duct or cyst-like structures. What's your definition of a cyst, for example?
So
for
a cyst, I would think of like a space lined by epithelium.
Good. Excellent. If it's got an epithelial lining and it's it looks like a hole, if you will, it's got an epithelial lining, you say, well, that's really a true cyst, or theoretically it could be a duct, like you said. That's a possibility, or some kind of an adenoma that's got ductal differentiation. So yeah, that's what. But if it's got a true epithelial lining, it's not cystic. Cystic means it's not really truly a cyst. It's actually an artifact, if you will. So this is a real, honest to goodness epithelial line space. So you're exactly right about that.
So it does look like almost glandular epithelium.
Good.
And then I think on the other slice, you could see kind of some, actually here too, some decapitation secretion, some like proteinaceous material within the cyst.
Okay. It's interesting. If you look really carefully, Can you see these little tiny hair-like structures on the surface?
Yes, I couldn't tell if those were cilia or just kind of fuzziness from the secretion.
It's actually, those are cilia, believe it or not. So some of this looks a little bit like apocrine decapitation secretion, but usually when you get that, you'll see most of the cells will be kind of demonstrating that. And most of these here are kind of flat and cuboidal. And then some of them have these sort of little protrusions. Some of that may be just tangential sectioning. And though those actually are, believe it or not, in this case, they are cilia. So this is a sort of a relatively somewhat of an uncommon entity. Here's another area down here. Can you see the cilia down here even more characteristically? These are kind of cuboidal cells. So these are really not apocrine cells here. It's a different type of epithelium. That sort of looks like decapitation secretion there, but they're actually, this is truly ciliated epithelium. And then you've got this area up here. Looks kind of unusual.
Yeah, so there looks like some acantholysis. I see some like light gray, purple cells, maybe
Okay.
some histiocytes with some lymphocytes mixed in.
How about all this over here? This sort of
Oh,
brown.
so that looks like some sort of pigment. So you can think like melanin or more likely iron or hemosiderin.
Good. Yes, this is iron. And there's one other clue. I mean, does this look like normal stratified squamous epithelium from, say, like somebody's back or somebody's arm?
No, it looks like kind of pale mucosa.
Yeah, good. Yes, good. This is close to the mucous membrane, actually, and it doesn't really have a classic stratum corneum. It's a little bit different. So this is an unusual entity. Let's look over here at this area. And you see this material here in the center of this, how that looks kind of similar to that other area we were just looking at. And here's the cilia once again at the surface. And the individual cells are kind of round and flattened, and in some areas they're kind of cuboidal.
Mm-hmm.
You probably don't know what this is, but did you have any ideas what it might be?
So I was thinking maybe cutaneous endometriosis with all the iron that I saw, but with
Yeah,
this.
that's actually what this is. So this is endometrial tissue. So that wasn't apocrine. Those were part of the endometrium that's got ciliated epithelium in some foci. And then all this is inflammation and secondary. This is just ectopic endometrium that doesn't belong here. And it actually was probably close to the mucosal surface. It probably was maybe vaginal skin right around that area there. You can see it's not really typical skin of like your, glabrous skin. It is mucosal epithelium. So yeah, this is cutaneous endometriosis. Probably won't ask you that on the boards. They possibly could, but this is what it looks like. And all of this material in the center is the deciduum of the endometrium. So the cutaneous endometrium that's ectopic undergoes cycling. This is usually always seen in premenopausal women who still have menstrual periods. And so this stuff also undergoes menstrual cycling, and you get the same changes that occur in the endometrium of the skin that occur in the endometrium of the uterus. So it's kind of an interesting phenomenon. It does characteristically have this sort of inflammatory infiltrate around the aggregations because it's not normally present. So the body's sort of trying to kind of get rid of it, if you will. You may get some eosinophils, you get some histiocytes there, but you commonly get this sort of stroma that's kind of edematous fibroblastic proliferation, and then you get these little cyst-like structures here. They're not truly cysts, they're really aggregates of the endometrium that's forming these ductal-like, cyst-like areas here lined by epithelium. That's really just kind of endometrial tissue that's implanted in the skin for one reason or another. So that's good that you were able to pick that up. So anyway, now you know what this looks like. So you've seen 2 or 3 fairly esoteric entities today in your first conference. Any questions about this? All right, well, thank you guys very much. Good job. And we will pick it up and do it again next month.
Thank you.
Thank you.
Take care.
Thank you.